Dr. Putnam, how did you become interested in research?
I was practicing in Fredericton, New Brunswick in the early 70s, and everybody in hospital has a role to play in the staff, and the one that gave me was the education coordinator, and so I worked with the person at Dal who was running the community hospital program at that time. And as I began to work with planning programs and watching them be implemented, I realized how little we knew about the impact of education on physician behavior. And so after a number of years of doing that, I talked with that gentleman, and he essentially recruited me to come back to Dal to join CME and to run that community hospital program from Dal, and in the process to get involved in research to improve the types of programs we do. So that's how I got interested. That's how I got interested in practice. In fact, there must have been some background interest, because I did research for 3 separate summers in med school. They really were research jobs with people who were doing research, not my own, but so I guess there must have been some pre-existing interest before I got in practice.
Okay. What was the first study you worked on?
It was called patient care appraisal, which is a term that has disappeared from language, if you will, but what it meant was it involved appraising care being given to patients and using that as a foundation for planning education, for planning behavior change, and therefore the education that would be needed for behavior change. And it involved asking physicians to be actually involved in the process of either setting guidelines or looking at recommendations that were out there and saying whether or not they fit their particular setting, and if so, why, and so on. And then we did baseline measures of behavior and then measures after involvement to detect change.
Okay. And what kind of change did you find?
Moderate.
Positive change?
Moderate. It was present. I mean, we showed that people who were involved in the process were obviously more engaged and made more changes than those who didn't, but it wasn't huge. These things are always incremental in terms of the impact they have.
Okay. What were you surprised by that outcome, or was it?
Probably. I was a novice at that time, and there weren't a lot of other people doing the same kind of stuff, so I didn't know what to expect. I think when you're involved in CME, continuing medical education, you honestly believe that everything you do is of great value and will change behavior. But in fact, after you've been in it for a while, you begin to realize that a lot of people are essentially practicing it close to optimal anyway. There's always room for improvement, but they're not doing all that badly, so there's not all that much room for change, and so the change you can measure is never huge.
Okay.
But once you get used to that fact and you get satisfied with incremental change, it's more satisfying.
So would you say that as of now, so how did that apply, and how did you work through your, over the years, you said there was incremental change, so it took some years to probably apply.
Well, I stayed in CME research, which is still predominantly 95% was involved with family physicians. It wasn't exclusive. There were some specialists involved in some of our projects, but it was mostly with family health. After doing about 20 years of that, I eventually shifted over to the Department of Family Medicine from CME, and at that point wanted to make a shift in my research just because of, I guess, I wouldn't want to say fatigue at doing that, but nevertheless I felt I chopped my bolt and it needed a change. So that was the time when clinical practice guidelines were becoming very common. Evidence-based medicine was being promoted in the early 90s, mid-90s, and so it made a gradual shift to studying the application of published guidelines in family medicine in primary care, and sort of gradually shifted that into more clinical, more clinically oriented work, which we'll talk about later if you ask me about where I think it should go in the future.
Okay. So where did your career go from there?
Probably, well, I gradually shifted from studying the impact of guidelines on primary care, and the ones we were using were cardiovascular guidelines, things around angina, management of myocardial infarction, basically coronary artery disease, because they were among the best evidenced guidelines at that point in time, and so it was the best ones to study. And so I kind of made a gradual shift into deciding to study those topics from a clinical perspective in primary care. And I put together a network of family docs in Maritimes interested in studying the management of hypertension, high blood pressure, in people with type 2 diabetes.
Okay.
And that's occupied the better part of 7 or 8 last years.
Okay. Can you tell us a bit about the outcomes of those studies?
Well, let's talk about the process first, if you don't mind.
Okay, sure.
That's really what was exciting me about that, and it's sort of my answer to your earlier email about what was one of the most rewarding things in my career, and that
Sure.
was actually involving 8 full-time community practicing family docs in a research project from the very beginning, from the describing of a question, the thrashing out of a question into a researchable question, from just a vague sort of what's going on with these folks kind of start, right through to the very end of publication. And many of them chose to be involved and have their name on our papers that we published. So that was an exciting thing, and it was very rewarding to me to see these people who obviously were interested in research, but never enough to make that a focus of their career. But they wanted to enrich their practice experience by involvement in a project. And so they did. They thrashed out the question. It took us 2 whole days to come up with the question of why is it so difficult to manage high blood pressure in people who have type 2 diabetes? And if we want to know that, what is it we have to find out? What is it we have to collect? What data do we need to begin to answer that question? So once they had that sorted out, Dr. Burge and I and others at Dow wrote up the protocol. Clearly that's not in their skill set. So we wrote up the protocol and got the funding, and there were 2 or 3 stages of the thing. But ultimately these people stayed on board while we collected the data. They helped us interpret the data after we collected it. They all participated in collecting it, as well as other docs who were recruited to do that. They helped with the interpretation, and at the same time the writing. Several of them actually wrote sections of the paper. The first paper out of that study was published in the Canadian Family Physician, and 2 of our team members wrote some of those sections and are therefore at the head of the list of those community doc authors, and the others who did all the other things necessary but didn't want to actually first author anything later on in the list of authors. So, and I made an exit interview, if you will, of everyone. I visited the practice. I did every year throughout the project. But for the last one, when we shared the findings earlier than that, but I went out around to discuss those things with them, and I was really pleased and impressed at how some of them were able to say how that involvement had changed their approach to practice and what they were doing differently. One individual told me that he had created signs for his waiting room, and he had processes in place for his staff to handle people differently. And so it was really, really very exciting to see that.
That's great.
The ultimate in knowledge transfer, involvement of the end users from the beginning to the end.
Right, right. Must be very rewarding after all that work.
Yeah, it was. It was a lot of fun.
Yeah. What was the most surprising aspect of, or surprising thing you discovered in your research?
I think I'd go back to a project I did about mid-career, and it was called the Change Project. That was the short term for it. And it was a project to interview physicians, and once again, the majority were family docs, but not all. Interview physicians about changes that they had made in practice, and then it would retroactively ask them, okay, why did you make that change? Where's the first time you heard about the need to make that change? Or where did you hear the information? Did you make the change then, or did you seek out other information before you made the change?
Right.
And we interviewed, and I'm forgetting these exact figures now, and hundreds, we had a team doing this, but interviewed hundreds of physicians and had thousands of changes that we needed to analyze to do it. It was a qualitative study. And what was, I think, surprising to me at that point, or maybe it shouldn't have been, was the richness of the interventions that physicians described that they did. In other words, they didn't just hear about something in a lecture and go back and change. They didn't just hear about something from a colleague and go back and change, or just read something and change. Generally, what they did was consult other resources. So if they'd heard about it in a lecture, they were likely to talk to a colleague about it. Have you done that? Did you hear about that? What was your experience with or if they heard colleagues say they were doing it, they'd consult a journal article or a paper, or maybe the next time they went to a CME course, they'd go to that session and listen to it before they make the change. So most changes involved 2 or more resources, if you will, and they were not of the same type. They were of different type. I don't think it's expected that.
Okay. Is there a question you'd like to see explored in family medicine? The other one that you'd like to do yourself, or?
Oh, there are many. I mean, pretty near everything I see, I think, gee, that'd be fun to follow that one up, wouldn't it?
Okay.
I just came from a session on the BP True. And we used the BP True in that study that I mentioned earlier about hypertension and type 2 diabetes. We gave every participating clinician a BP True machine. And we bought them and placed them in their office so that we'd have standardized measures. So I'm interested in the impact of BP True on blood pressure management and primary care. I'd love to be able to follow that up, but it won't be for obvious reasons. But I think that betrays what I think I'd like to see more of in family medicine research, and that is research around actual clinical care, research around the primary care aspects of common diseases. Generally speaking, chronic disease, because that's what bedevils us most, but nevertheless, acute things are fine too. Too much, not too much. A lot of what we have seen in the past done by primary care researchers has been either health services research or education research, like I was doing, and not enough, I don't think, of clinical questions like the one I just came from, which is looking at the impact of blood pressure, automated blood pressure measuring tool in the office and in the pharmacy. Very clinical-oriented thing. I'd like to see more of that from young researchers coming on.
Okay. Speaking of young researchers, what advice would you give to a young researcher going into the discipline now, or who wants to get into research?
I think to some degree my answer might be redundant because I think the younger ones are smarter and with more opportunities than when I started, but I do still see people who do not have specific research training. They have some sense of what goes on, or they may have done a master's with a snippet of research methodology in it, but they aren't really solidly grounded, and yet they want to make an impact. They want to do some research. And I really believe firmly that anyone who wants to do that as a significant part of their career should do a research-based master's and get a solid methodological background. Some would say they should get a PhD. I think there's a quantitative difference there. I think someone with a good, solid master's level education can do independent research or contribute well to a team. Mm-hmm. I think if we were talking to a resident in, say, first or second year who said, I want to be a career researcher, I'd say, yeah, go for a PhD.
Okay.
If you want to work in this trade for 35 years, you probably better get a PhD. But there are lots of people out there who are sort of mid-career and they've practiced for 10 or 15 years and they've been itching to do something and they're coming back. For them, perhaps a master's is an appropriate level of training, and a lot of the work they do will probably be in teams where there are people with PhDs or statisticians or methodologists.
Okay. What, in addition to the education, what personal qualities do you need? I mean, I heard you talk about your first study where it was unusual to have so many family doctors participate to the level that they did. Probably took some convincing, or I sense that there's a lot of personal quality, communication capabilities that you would need to be a good researcher.
Yeah.
Anything
I think they're
else?
hard to measure, but I think probably the single one-word answer to your question is a two-word. It's sort of an innate curiosity. Somebody who is aware of issues in their practice and wonders why. Doesn't just accept the fact that it's tough to manage hypertension, type 2 diabetes, and carry on, but somebody says, why? Why should that be? Is there something else that we're missing here? Is there something else we could or should be doing here? And so that probably, like I say, that's not something for which there's an easy measure, but that's how these 8 step forward. I wrote a letter to about 80, I think it was. It's a long time ago now, I can't remember. It's probably 10 years ago since I've made the initial inquiries here, but I sent a letter to everyone who was involved in our teaching program around the Maritimes, people who took residents or undergraduates into their practice, regardless of where they were working. Mm-hmm. Rural areas a long way from us or any other site. And out of that, I get about half wrote back that they were interested in participating in some level. But the 8 that participated were the ones that said, I want to be a part of something from the scratch, from the beginning, and I'm willing to put the time in. So that's how we got that 8. They responded to a one-page letter saying, we want to start a project involving our community teachers in research. Are you interested in what level of involvement would you like?
Okay. So that has to do with mentorship and encouraging others to put their minds to that. Who is, can you name one of your own mentors?
I mean, if you include the notion of encouragement and support, I'd have to go back to the guy who recruited me from practice in Fredericton. He must have seen some sort of potential, but he himself was not a researcher, so he couldn't provide me with the methodological support I needed. At that point, I phoned a researcher at McMaster, Dr. Jack Sibley, who was doing community-based research or using methodologies that I thought I might need, and he was very helpful. So he was probably the first supporter of that kind from a methodological sense. There were none. There were no other people at certainly in family medicine or in CME at Dal at that point who could have helped me with that kind of methodology. Jump ahead 20 years when I made a switch, 25 years, when I made a switch to family medicine full-time, it's been Fred Burge, who is research director at Dal, was then and still is, and is a well-trained individual. He's an example of someone with a master's in clinical epidemiology who has been able, with that background, to have a very successful research career. And so probably for the last, since 1995, what's that, 17 years? Mm-hmm. 17 years, my primary mentor at Dal would have been him. It's an interesting twist in that he's younger than I am by a fair bit, and at that point didn't have any more experience in research than I did, but he had training that I didn't have. So I think we can almost say we maybe co-mentored a little things that way. I learned a lot from him, and he may have learned a little from me. Who knows?
Good stuff. One of the things I hear a lot about is how do we promote family medicine research? Of course, there are the organizations, the cancer, the Alzheimer's, the heart and stroke, who, when people say give money, they're thinking of bench research and that sort of thing. How do we attract funding, recognition, acceptance of family medicine research as a discipline?
Boy, that's a good question. That's a tough one. I think we have to blow our own horn more. We have to look at the research that we do and think of ways that it is of interest to or has impact to the public, and then attempt to get publicity for that so that the public appreciates that primary care research is of immediate and direct interest to them. I can give you one example, and it's not a personal one, it's in our department. Our Fredericton site has a very active research program, and one of the threads in the past years has been cancer follow-up, particularly in breast cancer in women, by Dr. Miedema, and I think they have done a superb job of making the public in their area, around Region 3, I think it is, in New Brunswick, where they did the research, aware of the work that they did. Press releases, press conferences, talking to lay groups. I think they've done a wonderful job of doing that, and I think we need to do more.
Okay. Are there any projects that sort of sidelined you or stopped you in your tracks where you had to sort of regroup, pardon me, and something that sort of
Came out of left field.
Came out of left field that
Sure did. That one jumped right clean to mind. It's a long time ago, but it's a painful memory. Back in the era before the class of medications called statins were in wide use, the drugs available to help lower lipids, particularly cholesterol, had unpleasant side effects largely, or were not in wide use. Lifestyle was the predominant way of dealing with elevated lipids, diet change, exercise, and so on, and use of these difficult meds. When I say difficult, just difficult because they had side effects, not because it was difficult for us to write the prescription. It's difficult for the patient to put up with it. Anyhow, in that era, and with me not knowing statins were coming, we started a CME project to help physicians gain the skills to help people with those lifestyle changes with the meds. And, it's a long process to conceptualize an idea, get it written up, submit it. That takes 6 months many times. And then you wait till you find you get funding, and then sometimes there's time even after that before you can go ahead. So a long lead time. And then you get into the project. So several years after we did this, and we had got well into the project, statins came along and just, I say, blew us out of the water. In fact, changed the treatment of hypercholesterolemia so much that it was very difficult to get any meaningful results out of that particular project. And that was a difficult lesson, but nevertheless, you learn when you're young, right? You try to avoid such things again, and I've been careful since then to look out for things coming down the pike that I might not be aware of, but need to be. It's not always easy. You still get blindsided sometimes.
Sure.
I think, you will when you're doing trials, which that one was, because something else some other intervention may come along that fouls you.
Mm-hmm. Okay. You were a family doctor as well.
Yes.
And were you in practice during?
I practiced after graduating with a rotating internship because I graduated 4 years before there was a program at Dow.
Okay.
I did my rotating internship around the Maritimes and went to Fredericton, New Brunswick, and practiced in a multidisciplinary group of, I think there were about 40 physicians, and if my memory serves me, there were 12 family docs and 28 or 30, give or take, consultants of various kinds in one large clinic. It was a very satisfying practice environment. I loved it. And the only thing that took me away was the fact that I got a potential to get involved in research and education, and the time came. Probably wish I'd stayed there a little bit longer, but nevertheless the opportunity came and I jumped at it. After 6 years I was there.
Sure. Yeah.
And since then I've practiced part-time until 10 or 12 years ago in the Department of Family Medicine, but it's not the same as full-time, full service.
Yeah. Yeah. Thinking about all of the projects, perhaps in Canada, that you've been familiar with, your own, other people's, what's the major contribution of family medicine research to practice and to the healthcare of individuals?
I guess I don't know the answer to that question. I mean, if you ask that question of researchers, you get as many different answers as you did people, because I don't think there's any evidence to say which one has had the most impact. Certainly some of the things that I think should have had impact, whether they really did or not, I don't know, is some of the work done on blood pressure management and measurement by people like Martin Dawes and Marshall Godwin and other people at Queen's, Rick Birtwhistle, who have done things that clarify the role of automated machines in primary care. They've outlined how much better care can be with those machines rather than what we're doing now. They've done things to outline the ideal, or at least apparently ideal, interval for following people who are well controlled. Mm-hmm. I think that paper was pay-per-view a few years ago, if I'm not mixing up things. Mm-hmm. I think that's probably, as a group of studies, that's the one that I hope has had an impact anyway, whether it really has or not. But, if you ask me again in a week, I might think of something else. I don't know.
Okay, that's fine.
There's probably no single standout area in that.
Of the projects you've worked on, which has been the most interesting to you?
Oh, the hypertension and type 2 diabetes,
The hypertension.
for sure. Largely because of the involvement of those other practitioners. I mean, I think every other project that I've done has been a partnership of other researchers. I mean, people with a research interest and career, either a big part of their career or a minor part, but at least they were in an academic setting, and many of them non-physicians, that's fine and good. This particular project, because it involved people in the field, the actual end users of the information that we were trying to get, made it the most exciting, interesting thing I've done. And if I had to do it all over again, this is the kind of thing I would do again.
Do that one again. Okay. What famous person or perhaps a researcher would you like to meet? Is there anybody that you have not made the acquaintance of in your travels?
In primary care.
In primary care?
Well, I would do well to emulate my colleague at Dow, Fred Burge, but let's say I probably should reach outside of my own institution and say, you know, of all the people right now that I look to and see present and think of their involvement in sort of the background of organization and improving the environment in which we work, I really admire Rick Glazer at UT, and when he speaks, I listen. When he writes, I read, and I think he's doing great things. And I say, not all just his own research, but what he does in the background as previously as chair of our section, I guess, for a couple of years, and I know in his work with CIHR and the change of their attitudes towards funding of primary care.
Okay.
I probably should have picked somebody long, retired, and dead or something like that, rather than a living person.
No, I would think most people in the Canadian discipline of family medicine research know of Rick and the work he's done. I knew him many years ago, and I had nothing to do with research.
You don't disagree with me, huh?
I don't disagree with you. Could I ask you, if you hadn't been a physician, a researcher, was there another field that you might have gone into?
With tongue-in-cheek, I'll say I would have been a blues bassist.
Ah, very good.
Tongue-in-cheek, because I don't have enough talent to be a blues bassist, but if I did, that's what I...
Because that's your...
It was a hobby for a while, and I loved it, but yeah.
Okay. Did you study music as well?
No, not really. I mean, I took piano lessons as a kid like everybody else in my... not everybody else, but a lot of other people in my time. So I knew how to read music and had a sense of music, but I stopped that when I was junior high school or something, and then nothing again until we moved from Fredericton back to Halifax in 1975. And Halifax had a very strong adult music department then, evening classes and evening bands that were an adjunct to the school system for kids, which was also very strong at that point in time. And I decided that I would take up something different. And so I went over one night, and the shortest line was at that table. So I said, "What's over here?" He said, "Cello and bass." And I said, "Write me down for the bass."
Good
So that's how my bass career started. But I loved it. I enjoyed it. It was a stand-up string bass.
Yeah.
And I played probably 10 or 15 years in first classes and then bands in the school system. And then one at the mid-school. It was and still is a mid-school band. And I played in that for a decade or so. It was a lot of fun.
Very good. People tell me there's a relationship between mathematics and science, understanding and music.
I think there is. I mean, I read the same thing. I don't know if that's true or not. But,
Okay.
yeah.
Okay. Is there anything that you'd like to tell me that I haven't asked?
I think one of the things in the email that you sent me was what I advise people coming on, and in addition to the education issue that we did talk about, and I think what should sustain people is doing something that they really are interested in, if not passionate about. In other words, find a niche, a question or something that you are passionate about. If we're talking about research career. And then try to work with people that you enjoy working with. Either join a group or surround yourself with people that you enjoy working with. Because working on something you're interested in with people that you enjoy working with, how could life be any better than that?
It's about collaboration.
Exactly.
That's it.
Exactly.
Very
There's
good.
no solo. Well, there's probably no solo research
Mm-hmm.
these days. I'll stick probably